Astana Declaration of 2018 into actions delivering positive primary healthcare outcomes. My name is Paul Sinclair. I'm the chair of the FIP Board of Pharmaceutical Practice, and it is my pleasure to co-moderate today's summit with our FIP President, Mr. Dominic Jourdan. A few housekeeping rules before we continue. You'll see our panelists there. We'll introduce them with a little more detail as we progress through the webinar. A few housekeeping announcements before we get into the webinar. This webinar is being recorded and live streamed via YouTube. The recording will be available on the FIP website at events.fip.org. You may ask questions using the Q&A box provided, and we would encourage you to do so. You are welcome to provide feedback to webinars.fip.org. We encourage you to provide feedback so we can continually improve the quality of the digital product that we are developing on your behalf. I would encourage all attending today to become an FIP individual member at fip.org/membership.registration. Significant member benefits are afforded to all FIP individual members, and also the opportunity to link with the global pharmacist community. Next slide, please. The learning objectives from today's webinar. At the end of this global launch, participants will learn about WHO's operational framework on primary healthcare to translate visions into actions, to explore initiatives from FIP member organisations on primary healthcare, to engage in a high-level discussion on strategic priorities needed for pharmacists to strengthen primary healthcare. We would encourage you to join the conversation at #primaryhealthcare, #PHC, or #UHC. As mentioned earlier, my name is Paul Sinclair, and I chair the Board of Pharmaceutical Practice. I'm a practicing community pharmacist in Sydney, Australia. Primary healthcare, as outlined in the 1978 Declaration of the Alma Ata, and again 40 years later in the 2018 WHO UNICEF document, A Vision for Primary Healthcare in the 21st Century towards universal health coverage and the Sustainable Development Goals, is a whole of government and whole of society approach to health that combines the following three components: a multi-sectorial policy and action, empowered people and communities, and primary care and essential public health functions as the core of integrated health services. Primary healthcare oriented health systems are health systems organised and operated so as to make the right to the highest attainable level of health the main goal, while maximising equity and solidarity. They are composed of a core set of structural and functional elements that support achieving universal coverage and access to services that are acceptable to the population and that are equity enhancing. The term primary care refers to a key process in the health system that supports first contact, accessible, continued, comprehensive and coordinated patient-focused care. Building on the principles of the Declaration of Alma Ata, the Declaration of Astana was adopted at the Global Conference on Primary Healthcare in October 2018 in Astana. In the Declaration of Astana, member states reaffirmed their commitment to primary healthcare as a cornerstone of sustainable health systems for the achievement of universal health coverage and the health-related sustainable development goals. The 72nd World Health Assembly in 2019 welcomed the Declaration of Astana and urged member states to take measures to share and implement the vision and commitments of the Declaration of Astana according to national contexts. Today is the 25th of October, 2021, and it's the third anniversary of the World Health Organization's Astana Declaration on Primary Healthcare, for which FIP pledged its commitment to accelerate progress in strengthening primary healthcare. In 2020, the WHO published its operational framework for primary healthcare to translate the vision of the Astana Declaration into actions. To mark this date and showcase how pharmacists can utilise and contribute to the WHO operational framework, FIP presents today the digital FIP Global Summit on primary healthcare. The summit will host a high-level discussion with the WHO to explore the strategic levers needed for pharmacists to strengthen primary healthcare. Next slide, please. This is a brief overview of today's program, and we'll start shortly with FIP's primary healthcare journey. We'll then have an expose of member organisations translating the Declaration of Astana into actions and interventions, followed by the launch of the FIP primary healthcare microsite and a digital toolkit. The second part of the program is a panel discussion with the WHO and Dr. Shannon Barclay, and they're covering core strategic levers to strengthen primary healthcare. And the program will finalise with the launch of FIP's global commitment to action on primary healthcare. Next slide, please. It's now my pleasure in starting today's formal proceedings to present FIP's primary healthcare journey. It's my pleasure to introduce Dr. Catherine Duggan, the CEO of FIP. Catherine, the floor is yours.
Thank you so much, Paul. And again, good morning, good afternoon, good evening to colleagues across the world at our Global Summit today. Ahead of moving on, I wanted to say how delighted I am to attend the event today on the 3rd anniversary of the Global Congress in Astana. That Congress really enabled FIP to align our priorities and focus our strategic delivery for the years ahead. We'll now move to the next slide where we have a video that summarises these steps for today.
According to the World Health Organization, primary health care addresses the majority of a person's health needs throughout their lifetime. This includes physical, mental, and social well-being, and it is people-centered rather than disease-centered. In 1978, world leaders and experts in healthcare got together at the International Conference on Primary Healthcare in Alma-Ata, Kazakhstan, and committed to health for all in the Declaration of Alma-Ata, which emerged from the conference as a major milestone of the 20th century in the field of public health, and which identified primary health care as the key to attain the goal of health for all. In 2018, on the 40th anniversary of the Declaration of Alma-Ata, the Declaration of Astana on primary healthcare was published, reaffirming the commitments expressed in the ambitious and visionary Declaration of Alma-Ata. Member states of the WHO, non-governmental organisations, professional groupings, including FIP, recommitted to strengthening primary healthcare to achieve universal health coverage and the United Nations Sustainable Development Goals at the Global Conference on Primary Healthcare held in Astana on the 25th and 26th of October 2018. After pledging its commitment to the Declaration of Astana to accelerate progress in strengthening primary healthcare, FIP started in 2019 to deliver regional conferences to commit to action on primary healthcare across all WHO regions. 2 regional conferences took place for the Eastern Mediterranean region in Jordan and for the European region in Turkey, where participants pledged to the Amman Commitment and the Ankara Commitment to Action, respectively. These are the regional roadmaps to support pharmacy colleagues in strengthening pharmacy's response on primary healthcare. The launch of the FIP Development Goals, FDGs, in 2020 has been a milestone in advancing the pharmacy profession over the next decade, globally, regionally, and nationally, with wider global imperatives underpinning the UN SDGs and achievement of universal health coverage. The FIP DGs form a foundation for systematic action to meet national, regional, and global healthcare needs, including primary healthcare. 2020 also marked the launch of the FIP Regional Conference for the European Region Report, which acts as a unique evidence-based resource on pharmacy needs and priorities assessment in the European region to deliver the next breakthroughs in pharmacy for better primary healthcare through the implementation of the Ankara Commitment to Action. Towards the end of 2020, the WHO and UNICEF introduced the operational framework for primary healthcare, for translating the vision of the Declaration of Astana into actions. These actions can be used to accelerate progress in strengthening primary care-oriented systems and ultimately lead to an improvement in health for all. Building on the FIP DGs, and the WHO and UNICEF's operational framework on primary healthcare, FIP introduced the FIP Commitments to Primary Healthcare Programme at the FIP Global Summit on Primary Healthcare 2021. The Global Summit celebrated the publication of the FIP Global Call to Action on Primary Healthcare, with the aim of pledging pharmacy's global commitment to strengthening primary healthcare, and the launch of the FIP Primary Healthcare Digital Toolkit, which aims to advance the capacity of the pharmaceutical workforce on primary healthcare. 2022. FIP plans to deliver regional primary healthcare engagement events and global summits to continue identifying and addressing global, regional and national priorities on primary healthcare with FIP members. 2023, and plans to report progress on FIP DGs and FIP's global commitment to action on primary healthcare at the anticipated Health Ministers Summit in 2023. By 2030, universal health coverage across all regions will be established through pharmacy's contribution to delivering primary healthcare, underpinning the achievement of the FIP DGs and the UN SDGs. Together, we can and we will achieve universal health coverage, good health and well-being for all, leaving no one behind.
Thanks so much, team. So, as Paul mentioned previously, this slide details the progress that we have made over the past 3 years. 2018 saw the signing of the Astana Commitment, 2019 saw the adoption at the World Health Assembly by all member states, and 2020 saw the publication of the operational framework amidst the emerging pandemic. The operational framework proposes 14 levers to translate the global commitments made in the Declaration of Astana into actions and interventions. This will accelerate progress in strengthening primary healthcare-oriented systems and lead to improvement in health for all. As we see in the next slide, alignment of the FIP goals to those levers is essential. That way, we get the synergy that's needed. We make sure that we're delivering our part in primary healthcare, and we're also ensuring that our countries and our member organisations are supported to do so. The next slide details the final levers as well. And if we move to the next slide and do another click, please, we agreed that we would collate and collect all that we've done since January the 2020 to map and track and visualise the key outputs and responses our profession has made in COVID. We think this is really important because primary healthcare is dependent on having good public health infrastructures, and everything we can learn across our member organisations and nations will support us in delivering primary healthcare as we emerge out of the pandemic. We presented this approach to our FIP members at our council in September, and then we have asked all our member organisations to help us evidence their responses at every 100 days since the start of the pandemic. We're taking the date of January the 30th as day one. We plan to publish the collation of work and the priorities for 2022 on the 1000th day of the pandemic, which is exactly this day next year. And we think that's very timely. The 1000th day of the pandemic, whatever stage our nations and our regions are at, will provide us with a really good focus on how we might prepare ourselves for the next one and how we might emerge from the pandemic to deal with the universal needs in each of our nations. These years can be described as 2020 responding to the pandemic, this year living through and with the pandemic at our different stages, and then next year preparing for future pandemics. In the next slide, you can see an animation of how the FIP development goals and the FIP programs can enable the WHO UNICEF operational framework and support all of our member organisations, countries, nations, individual pharmacists, pharmaceutical scientists and pharmacy educators to deliver their role in universal health coverage. Alignment, collaboration and coalitions provide us with the solutions for this. Thank you so much. Now I will hand over to Paul.
Thank you very much, Catherine. And a very clear pathway, an ambitious pathway, clearly shown for FIP's primary healthcare journey through to 2030. It'll be a great thing to be part of that journey. Thank you, Catherine. It's now my pleasure to introduce the next part of the program, where we have member organisations with presentations showing pharmacy translating the Declaration of Astana into actions and interventions. This will be done across 6 WHO regions. And the first of our presentations tonight comes from the Eastern Mediterranean region, from Dr. Zayed Kilani. Dr. Kilani is the president of the Jordanian Pharmacists Association, JPA, and is a member of the steering committee of the Medical Health Access in the Scientific Research and Innovation Support Fund by the Ministry of Higher Education and Scientific Research. Dr. Kilani is also a member of the Royal Committee to Modernise the Political System. His presentation today on behalf of JPA will be on introducing vaccination and improving physical infrastructure. Thank you, Dr. Kilani.
Thank you very much, Paul. It's honestly a pleasure to be part of this important summit. And I'd like also to say, for whoever put the title, you do give us more credit than we deserve, but really, thank you very much. My name is Dr. Zayed Kilani. I'm the president of Jordan Pharmacists Association, and it's my pleasure to be here with you today. I'm taking you back in time for 2018, where the first FIP conference, a regional conference, took place in Amman. As you can see in the picture, me and Mr. Dominic Jordan were signing the commitment into action, Amman commitment into action. It was taking the primary healthcare through adoption of the Astana Declaration, emphasizing on the big role pharmacists have in primary healthcare. The next slide will show you what actions we did. After that, it was very important for us to take in place what is needed. So our first endeavor was to allow pharmacists in Jordan to start administering vaccines in their pharmacies. And here you can see the letter from the Ministry of Health, signed by the Ministry of Health, allowing pharmacists to start giving seasonal vaccines like the influenza vaccines on site in the year 2020. The next slide will show us what we actually did. We needed to prepare the physical infrastructure, of course, and prepare the pharmacists to start giving the vaccination. So the pharmacists went through a training on how to give the vaccines. We also, they have undergone training for CPR, first aid, and thanks to a committee, vaccination committee working within the JPA in Jordan, headed by our own Dr. Samira Qsous, established or published the Jordan Community Pharmacist Immunization Guideline, where it was given to all pharmacists. After that, we got the approval, the pharmacists were certified, and they got approval from the Jordan Food and Drug Administration to start giving vaccines within their premises. That was not an easy fight. It actually took us a long time to convince the authorities to start to reach this goal. And when I say I'm going to take a little bit on this slide, just telling you what we needed to go through to make this happen. We went through the whys, let's say, why and when, where and who. Why and when is the primary healthcare? Primary healthcare would really help the governments, the social security, the insurance, to lower their bills for the secondary and tertiary treatments. And sometimes you can go as easy as a statement that is well known to everybody, rather than just keep on giving the old studies and documents from best practices. In Arabic, it's the statement I've written here, dirham wiqaya khayrun min qintari ilaj. An ounce of prevention is better than a pound of cure. That's literally what primary healthcare is. So after reaching that stage, we went to where would they take the vaccinations. Pharmacies. Why pharmacies? Pharmacies are spread everywhere, at least in Jordan. It's available in most of the neighborhoods, in rural areas, in villages. It has the ease of access. It has the availability. Patients can go in without any problems, no need for appointments. And that takes us to who? The pharmacists. They are major role players in the primary healthcare. They are the most trusted healthcare provider teams, and they're available. And the patient or the public would go into the pharmacy within 5 minutes, would be taking his vaccine, their vaccine, and leave happily. This also, next slide, please. This also took us to an important era in Jordan where the pharmacists actually flourished in primary healthcare. COVID-19 crisis and the lockdown. JPA was able to convince the government and authorities when the lockdown happened that pharmacies cannot close or shut down. So pharmacies and hospitals were the only centers for healthcare that were open at that stage. The hospitals actually were open for emergency cases. So it was left for pharmacies and pharmacists within those pharmacies to provide any healthcare needed for the patients. And even if the case needed, they would refer them or tell them go immediately to the hospital, emergency, or would call the doctor to go at home. And that's where everyone realized how important our role as pharmacists is in primary healthcare. That also put the light on the pharmacist for them to start even vaccinating the COVID-19 vaccine or administering the COVID-19 vaccine. And that also took place in Jordan. If you see what happened in the next slide, we established a center for vaccination in the Professional Association Complex, which is the headquarters for Jordan Pharmacists Association. Pharmacists were volunteers during the crisis and were able to vaccinate 15,000 people in that time. We also have other projects, engagement with private and public sector. The role of pharmacists as it flourished during that period, the authorities realized how important our role is and how easy it is to communicate with pharmacists. So a memorandum of understanding was signed in this year, allowing pharmacists to have mobile teams. Of course, it is a public-private sector, public-private collaboration, where pharmacists from the private sector would work with authorities from the public sector to vaccinate people in rural areas, in their homes, elderly that could not go to centers of vaccination centers. And that was another win for pharmacists in Jordan. This will take me to my last slide, which is still work in progress. And it is part of His Royal Highness Crown Prince Hussein bin Abdullah initiative for encouraging the public to take the vaccines, especially in the remote areas and rural villages. The National Center for Security and Crisis Management chose the pharmacists to start a pilot test in a couple of areas. And I am pleased to tell you that just before this meeting happened, I got a phone call from one of the pilot areas saying how pharmacists were able to spread awareness and promote the importance of vaccines and convince the patients or the public within their area as neighborhood pharmacists and as their consultant and trusted consultants to take the vaccine. And hopefully within the coming 2 days, the mobile teams will go to that area and vaccinate over 100 persons from the public. And that was actually a dilemma for the government. How would they reach those people? And the best option was to reach them through pharmacists within their pharmacies within that area. By that, I hope this is another success for the pharmacists in Jordan. And I thank you for having me with you today.
Thank you very much, Sid, and congratulations to the JPA on achieving those milestones with vaccination, and clearly the importance of well-planned advocacy and also leveraging the COVID pandemic to highlight the potential of the pharmacist and what they can do in Jordan. So thank you very much.
Thank you, Paul.
Our next presentation is from the African region on behalf of the Pharmaceutical Society of Kenya. and it's my pleasure to introduce Dr. Eric Moringu. Eric is the project's lead for the Pharmaceutical Society of Kenya. He's in-country consultant for the Commonwealth Partnerships for Antimicrobial Stewardship and manages projects on health advocacy, frontline patient care, and supply chain in the humanitarian sector. Eric, welcome, and we look forward to your presentation.
Thank you, Paul. I'll dive into the presentation. Next slide, please. Thank you. So at PSK, we have a program running for 3 years named Kamba ya Shanga. I would like to make a brief background of where we are coming from. In Kenya, currently, we have a very young universal health coverage program that was launched in 2018. So, and the focus of that, you'd see basically is primary healthcare. That's where we thought as pharmacists we can come into play. So this program is a partnership between Pharmaceutical Society of Kenya and AstraZeneca. AstraZeneca playing a supportive role, but the implementation is by Pharmaceutical Society of Kenya through the network of pharmacies, which are our members. So basically, Kamba ya Shanga is Swahili, which means a stream of beads. So this is an interconnection of all the players in the health continuum that links them together to platforms, bringing into play the pharmacist, who is the community pharmacist, the patient, and this patient we talk about those with chronic conditions. So we've started with asthma management. Hopefully that will grow after we've seen the results of the project, will grow into other chronic conditions. So in play of the pharmacist, the patient, the general practitioner, PSK is an overarching body. Then a digital platform and what there.
Eric, sorry for interrupting. We are having difficulties to hear you. Do you mind turning off your video so we can hear you better? Sorry for interruption.
Thank you, Nilhan. Can you hear me better now?
It's better.
Thank you. So I was explaining how the program flows. So we have a patient that visits the community pharmacist. Maybe let's go to the next slide, please, which is what I'm talking about now. Thank you. A patient visits the community pharmacy. The pharmacist will identify patients who are currently on asthma drug medication. At that point, the pharmacist will offer to give a consult to the patient or a medication review, and they can ask the patient for an appointment, to be booked for an appointment, which the pharmacist will use a medication therapy management tool. This data is recorded in an online platform. So a follow-up consult is uncontrolled or managed patients. Referral is done to the general practitioner. Next, please. So we hope to, through that, we involve all the players in the health continuum. That's the patient, the general practitioner, so sort of multi-sectoral integration. By that also, we want to empower patients to be self-carers of themselves. The outcome of which will be better management of patient conditions, patients being counseled enough to know what their condition means, why they are in certain medications, what medications to avoid when they're in those medications. And from that, because of our still universal healthcare coverage in the country, we hope to get into the discussion of benefits package because our UHC is still evolving. So we want to inform that process by the data that documents the impact of a pharmacist at the community level. So basically, we bring into play the use of digital platforms, which is technologies, a level of the primary healthcare, a level of the primary healthcare strategy, and also by documenting the impact of the pharmacist at the community level, we hope that this will lead to a better understanding of how best a pharmacist-led disease management program can be incorporated nationwide. Last slide, please. Yeah, so this is a low-touch innovative solution, which we hope will be interested to see how it pans out. And also we are excited to see exactly the impact, because we start at a baseline that has zero data. So we want to see at the end, the data that we get from there, how best can we leverage on it to inform policy. So we'll generate real-world evidence of the impact of the pharmacist on patient outcomes, and also the larger conversation of primary healthcare at the as given by our umbrella body FIP. So thank you so much. That is the end of my presentation.
Dr. Maringu, thank you so much for that presentation. Interestingly, the notion of empowering patients to be self-carers is so important in shifting some of the responsibility of individuals' health back to themselves. And that's something that we're seeing more and more of. And also the template that you used in that asthma program could be used in any marketplace. That looks like a very interesting program. Thank you. Our next presentation is from the Americas region, and I welcome Ms. Anne L. Burns. Anne is the Vice President of the Professional Affairs of the American Pharmacists Association, APHA. Anne leads their initiatives on pain management and the opioid crisis, and also works on medication management, health IT, medication safety, and credentialing and privileging programs. Anne will discuss today purchasing and payment systems, practice sustainability, and payment reform in the US. Welcome, Anne. The floor is yours.
Thank you, Paul. On behalf of the American Pharmacists Association, or APHA, I sincerely appreciate the opportunity today to highlight US initiatives to achieve practice and payment reform for pharmacist patient care services. Next slide. Payment reform is APHA's top priority and a significant priority across the pharmacy profession. We all know that pharmacists are highly trained medication experts, yet in the US, sustainable payment for their clinical services is a significant barrier to leveraging that expertise in the primary healthcare sector and beyond. Next slide. APHA's strategic efforts are focused on optimizing scope of practice authority to allow pharmacists to fully use their education, training, and skills, securing payment to support service delivery, and advocating for pharmacists' recognition as valued healthcare providers. In the US, pharmacist scope of practice is primarily regulated within each state. This leads to variability in practice authority. However, during the pandemic, temporary federal authority has been granted for pharmacists to order and administer COVID-19 vaccines, tests, and more recently, treatment, with corresponding payment models. This has been a game changer for us. Pharmacists have made significant contributions and really appreciated the Jordan presentation because we have seen similar successes in the US. This has elevated public recognition and enhanced the value of pharmacists as primary healthcare providers. When we look at factors such as pharmacist medication and health expertise, their accessibility to patients, and their ability to and their ability to impact quality metrics, all of these factors are strong supporters for pharmacists as part of the primary healthcare workforce. Next slide. The two common predominant payment models in the US are fee-for-service and value-based payment models. In fee-for-service, providers receive a payment for each service delivered, where in value-based payment models, payment is tied to quality and cost metrics, and payment is focused on paying for outcomes. Value-based models are founded on the quadruple aim, which you can see on this slide. These aims, interestingly, are also instrumental in delivering effective primary care. We have many different types of value-based payment models that are currently being tested in the US, and the number of these models is growing. Our strategies at APHA focus on payment for pharmacist services in both of these models, fee-for-service, value-based, and we're also seeing blends of the two. Next slide. In the US, we have a public-private payer mix for healthcare that requires multifaceted strategies in order to achieve our goals. At the public payer level, which is our federal level, the focus is on using a coalition to pass legislation in our Congress to recognize pharmacists in their patient care services in our fee-for-service Medicare program. Medicare serves as a guidepost for many other payer programs, and so this is a critical initiative for us and other organizations in the profession. We are also working with federal regulatory agencies to make the temporary authorities that have been granted to pharmacists and the corresponding payment permanent. We also are working with the agencies to maximize their authorities for pharmacist practice and payment reform. At the state level, we are seeing many innovations to drive pharmacy practice from both a scope and payment perspective. Many states are authorizing pharmacists to prescribe medications for public health needs, such as oral contraception and tobacco cessation medications. And some states are implementing payment programs to support those services. We are also seeing what we call payment parity laws that provide pharmacists with payment if pharmacists' scope of practice allows them to deliver services that commercial health plans pay other providers for. So it's kind of like an anti-discrimination law. It's really the innovations in the states, across all 50 states, that are driving a lot of our practice and payment reform efforts. And then finally, in the private sector, private health plans are increasingly interested in engaging with and paying pharmacists. Key interest areas are pharmacists' ability to close care gaps, provide access to care, and helping health plans to meet their metrics. It's in this sector where we're seeing significant interest in value-based payment contracts. Next slide. I'm not going to spend time on this slide, but just wanted to present it to show all of the different initiatives that are also ongoing to support pharmacists being able to provide patient care services and become valued members of the primary healthcare workforce. That's the conclusion for my presentation, and I look forward to the Q&A.
Thank you very much, Anne. And you've really highlighted one of the big challenges for all pharmacists and pharmacist associations, and that is if you want to have a sustainable service delivery of professional services, then you must be supported by a viable remuneration model. And that's key to expanding the range of services you provide. But looking forward to coming back to you with some Q&A, and thank you very much, Anne. Our next presentation is by Dr. Anusha Schut from the Royal Dutch Pharmacists Association, and she'll showcase some of the work that is being done in the European region. Dr. Schut is head of the Policy and Development Cluster at KNMP and is a member of the management team of the Pharmacists Association KNMP. She's an expert in strategy, public affairs, regulation and finance in healthcare and social security. She will give us today a presentation on managing shortages in daily practices in the Netherlands. Dr. Schut, thank you.
Thank you so much, Paul. Next slide, please. Yeah, in this presentation, I will tell you about how drug shortages are managed in the Netherlands during daily practice and during the COVID-19 crisis, and what the role of the Dutch KNMP is. Next slide, please. Yes, sorry. This figure shows the increase of drug shortages, a sharp increase since 2012. In 2019, the shortages have even doubled compared to 2018. As you can imagine, this threatens the continuity and quality of pharmaceutical patient care. The problem is with shortages that parties use their own definition with their own level of abstraction. There are also differences between countries. Drug shortages are a worldwide problem, but the lack of a clear definition makes it difficult to compare between countries. The Dutch KNMP speaks of a shortage since 2004 if 3 criteria are met. A medicine is not available nationally. The expectation is that the shortage will last longer than 14 days, and the report from a pharmacist has been verified by KNMP Pharmanco at the manufacturer. Next slide, please. The cause of drug shortages. Due to globalization, the different steps in the production process are increasingly taking place in many places in the world, as we all know. The production chain has become longer, more complex, and more vulnerable. Dutch patients and pharmacists can immediately be confronted with a drug shortage if a problem occurs at one of the many links in the chain. Prices in the Netherlands have fallen sharply over the years as well. Combined with the low population and low drug consumption, the low prices make the Netherlands a relatively uninteresting sales area for drug manufacturers. As soon as a shortage arises, the Netherlands is at the back of the queue when it comes to the supply of medicine. Dozens of medicine with a too low yield are withdrawn from the market every year, and one shortage is leading to other shortages. Next slide, please. As a result of shortages, pharmaceutical care starts too late or has to be interrupted. And in the worst case scenario, the patient may not even be treated at all. The 2019 annual report of the Dutch Health and Youth Inspectorate even states that drug shortages are a risk to public health and can cause social unrest. Solving shortages costs the pharmacy team a lot of time and work, as you can see on the slide, and has a very high impact. Next slide, please. With a great deal of expertise and effort, pharmacists in the Netherlands succeed in providing patients with medicine, also for 99% of drug shortages. But the patient generally suffers from this. This graph shows how the shortages for patients are solved by the pharmacy team. Next slide, please. 80% of the shortages were resolved within 6 months. The Dutch Ministry of Health has now allocated financial resources to establish the so-called iron stock to solve shortages. Next slide, please. Increasing questions from pharmacists about drug shortages and solutions for patients led us to facilitate our members in managing shortages during daily practice. So we came up with the idea to provide centralized information on shortages. And we need accurate information about this, and as you can see on the slides, which information we need. Next slide, please. KNP Pharmanco has been informing about drug shortages in the Netherlands since 2004. In 2020, there were over 1 million views on the website and currently about 400 cases of drug shortages on this website. And as I said before, there are a few things necessary, criteria necessary to be met before we publish them. Next slide, please. I will focus a bit on the method we use because I think this is interesting to our viewers. In this decision tree, you can see the method which KNP Pharmanco uses. On the website, a medicine shortage can be reported by industry or pharmacist. And based on this report, the manufacturer is contacted for an analysis of the problem, such as the reason for the shortage and duration. And if there's an actual shortage, the first step KNP Pharmanco takes is to check whether substitution is available. Substitution is an identical registered product with the same active ingredient and preferably in an identical pharmaceutical form. And this is the best solution, of course, because the patient doesn't need to change to a new drug. If substitution is not available and not possible, the next step is to check whether a pharmaceutical alternative is available. This is a registered medicine with a different active ingredient. The choice for a pharmaceutical alternative is based on national guidelines and treatment protocols. It can also be widely supported advice from the specialist associations. The advantage of a pharmaceutical alternative is that the medicine is registered in the Netherlands and has therefore been assessed by the Medicines Evaluation Board. Therefore, a Dutch package leaflet is also available. The disadvantage, however, is that the patient has to change and adjust to a new drug. If the originally prescribed active ingredient is nevertheless necessary because of pharmacotherapeutic purposes or is preferred for reason of patient friendliness or medication safety, import or pharmacy preparation may be an option. Next slide, please. Sometimes a medicine is available in another country and can be imported. Disadvantages for the patients is, of course, that the product from abroad has a different name and appearance. Importing also takes time and is complicated because of, for example, arranging an import license. An additional problem is that a patient may need to pay extra costs. Insurers do have a reimbursement ground, however, if one of two conditions are met. The Health and Youth Care Inspectorate has given their prior consent, or the Medical Evaluation Board has granted temporary market authorization in the Netherlands if the import is already marketed in the EU. These reimbursements are both temporary. In practice, health insurers apply different, sometimes additional conditions and reimbursements for import of medicine and transport costs. And as a result, the costs ultimately end up with the pharmacist and sometimes even with the patient. Next slide, please. In summary, these are the solutions for drug shortages we present on KNP Pharmanco, the website which I've presented in the previous 2 slides. Next slide, please. Yeah, where do we get our information? I won't go through everything because of the time, but I'll focus on substitution and the pharmacy preparation. Substitution, we check the G standard And the G standard is the Dutch drug database, and it contains all the products that are dispensed by or used in the pharmacy. The G standard covers information about licensed medicines and unlicensed medicines, for example, raw materials and compounding preparations. To each care product, information is added, for example, about pharmacovigilance, price, logistics, and the reimbursement policy of various health insurers. And of course, we will check substitution with the supplier as well. Concerning pharmacy preparation, also in the ownership of the KNP is the Laboratory of Dutch Pharmacists. They have a publication of National Formulary, FNA, and it contains formulations for 200 medicines which are prepared in the pharmacy because they are frequently needed but not on the market. And in case of shortages, they may develop a new formulation so pharmacists can prepare it. Next slide, please. Yeah, the Dutch Ministry of Health is working with all members of the medicine shortages working group that contains all stakeholders to solve supply problems and medicine shortages. And one of the possible solutions being discussed is stimulating production close to home in the Netherlands and the EU. The role of the EMA is being seen as very positive by the Dutch government in monitoring shortages of medicine and medical devices. And the government is also looking forward to the EC's result on the visit and possible solutions. Stockpiling is seen by the KNP as one of the measures to combat drug shortages. Holding larger inventories at manufacturers or wholesalers for 5 months can solve over 80% of the shortages. The construction of iron stocks was announced in the Netherlands in 2019, and these stocks should be ready in July 2022. And then the final slide, please. Yeah, the consequences of COVID-19. Thanks to the efforts of many pharmacists, but also other healthcare workers in the primary healthcare, including hospital pharmacists, there have been no shortages in the Netherlands as a result of COVID-19. At the time of the shortage of the midazolam injection, hospital pharmacists have prepared midazolam from raw materials, but the situation was worrisome at times. Responding to a greatly increased demand by increasing production appears to be virtually impossible due to the inflexibility of the current system, as described earlier. It is not clear which effect the corona crisis will have in the medium to long term on the availability of medicine in the Netherlands, partly due to the complexity of the whole chain. Thank you so much.
Thank you very much, Dr. Schut. That's a very enlightening presentation, and medicine shortages are something that is being faced in every marketplace. And the KNP's approach is I think similar to others, and it's a case of how effective it can be. So thank you very much. That's much appreciated. Our next presentation is from the Southeast Asian region and from Indonesia, the Indonesian Pharmacists Association. It's my pleasure to introduce Mr. Roy Himawan, the Deputy Secretary General of the Indonesian Pharmacists Association. He's Head of Program and Information Section Secretariat of the Directorate General of Pharmacy and Medical Devices in the Ministry of Health. He serves as the National Professional Officer for the Workforce Transformation Program, and Roy will be talking to us about the pharmacist role in primary health care. Roy, thank you. The floor is yours.
Thank you, Paul, for the opportunity given to me. So, on behalf of Indonesian Pharmacists Association, I would like to say thank you to the FIP for this opportunity to share what is our experience to the summit about the Pharmacy Workforce Transformation Program, which is a collaboration work between Indonesian Pharmacists Association with FIP in implementing the WHO and UNICEF operational framework for primary health care. So I would like to to present in 3 subtitles, which is the burning ideas of to transform pharmacy workforce. What is the ID when we want to work on transformation of pharmacy workforce? And the second is, what is our progress on this transformation program and our map in WHO levels. Next slide, please. So when we talk about workforce transformation program, we were very grateful that having the Declaration of Astana being established in 2018. When we know in this declaration to be able to primary healthcare to be developed, we need to create decent work and appropriate compensation for health professionals and other health personnel working. We need also to apply knowledge, and we need to support access to healthcare services through the use of high quality, safe, effective, and affordable medicines. And also all of this only can be done if we transform our pharmacy workforce to occupy with this declaration. And the other aspect that we had that in 2017, we are lucky to have our colleagues had research on the needs of a pharmacy workforce in Indonesia to be transformed. So from the research, we know that all the pharmacists of the subject of this population, they are eager to develop an advanced practice of pharmacists. So the pharmacists feel that we need to do more and more besides of those standards now, and with that, by doing more, we will be gain more attention and more appreciation for other health professionals. So this research confirm these findings, and also this is in line also that we are also grateful with the Ministry of Health Policy or our National Ministry of Health Policy when they are intend to develop the green design of health workforce career development for the next 5 years. So in our country, the health workforce is being mapped for the career, and this one for the health professionals outside of medical professionals, it's still a new one, including for pharmacists. So we are lucky to have the policy that our ministry will bring a grand design of health workforce career development in the next 5 years. So next slide. So I would like to tell the progress that we already done up to now. That started in 2019. We signing the Memorandum of Understanding between Indonesian Pharmacists Association with FIP take place in Abu Dhabi in 2019. And then after that, we consolidate our vision, and we advocate our stakeholders to move along with us to the agenda of transformation. So when we know that transformation is a vision, so we consolidate the vision, and then we share it to our stakeholders. Our Ministry of Health, as shown in the picture in the below, and also our national accreditation committee when they want to accredit our practice professional, and our national agency of standard when they want to create the standard for doing professional practice. And from that, we are moving to the creating the Indonesian Advanced Development Framework, which is for the first time we create in this country the framework for pharmacy practice for all of kind of pharmacies. This is the uniqueness of the workforce transformation program, that it can be involved, it can be established in every kind of setting of pharmacy workforce, whether in the industrial place, whether in the community pharmacies, whether in the hospital pharmacies, or even in the public health pharmacies. There is a room for improving our practice through the workforce transformation program, which we have set up, as you can see on the upper diagram, that after you finishing after you complete the formal education, there will be a step for you, for pharmacists, to build and to gain your more and more career upstairs. And then after that, before we conclude our program, we are managing now. We are in preparing our professional recognition system, which is a system that conduct, which is designed to recognize your practice and recognize your experience through the scientific method, which is in collaboration with Ministry of Health. Next slide. And for the implementation, we also had performed the national training program, which is enrolled to provide environment for the advanced practice pharmacists, making the environment available for the pharmacists to know how can we do the advanced practice in our setting. So we have done this national training program in 2 batches. The first batch is conducted in 2020 with collaboration with FIP, which is with the goal to provide FIP training and development strategies in a patient-centered approach for pharmacy trainers. So in this batch, we have 63 pharmacists carefully selected from more than 200 enthusiast pharmacists that registered and showed their commitment. And then because the limitation of the capacity that we have, we only can select 63 pharmacists. And based on the evaluation, most of participants stated that this training meet their expectation, their needs, and their proposed follow-up activities. And for the second batch that we had conducted just a few months ago, conducted into 2021 in last August, when it constructed with our annual scientific conference, with the goal to provide experience on identify learning needs by focusing on the global competency framework, which has been provided by the FIP as a guide for their personal development. So in this batch, in this phase 2, we have 59 pharmacists from the phase 1 having training to identify the learning needs and to propose their learning development program. The next slide. So I would like to say that with the workforce transformation program, we are convinced that we are mapped to the WHO and UNICEF operational framework for primary healthcare. With this transformation program, we believe we can build the competent workforce to build a successful model of care which is needed on the primary healthcare. With this transformation program, we also believe that we can build an adaptable, flexible, and capable primary healthcare pharmacists that will support with other health professionals in building a resilient primary healthcare. And also with this transformation program, we believe we can make pharmacists be more responsible and involved in all aspects related to the quality assurance of medicines and other health products used in the primary healthcare settings. Also, we believe with this transformation program, we engage with the private sector providers to develop professional recognition system and advance primary healthcare workforce. And also, this is raise a question for us for the continuity, and we are striving our stakeholders to convince with us to engage with us in this program. And also, with this transformation program, Indonesian Pharmacists Association developed digital technologies for our member. We have a system that identify all of the 80 million members of our organization across the nations in data. So we have the profile of them, profile of their daily practice, and we can show you in another session. And also with this transformation program, we want to provide the data, the documentation that can lead us to the primary healthcare oriented research, and also to do the monitoring and evaluation. So I would like to close my presentation with the next slide that will show you about what we are doing in the primary healthcare setting, where the pharmacists work hand in hand to provide access for medicines for primary healthcare services across the nation. We had a very different condition of our country, from the mountainous to the archipelago setting, in island setting, in remote areas, and also by introducing the home pharmacy care for all of our people across the nation. So I would like to stop my presentation here and I'll give it back to you, Paul. Thank you, Paul.
Thank you so much, Roy. And it's nice to see the acknowledgement that without a properly trained and skilled workforce, it's very hard to improve scope of practice. And congratulations to what you're doing in Indonesia. Our next presentation comes from the Western Pacific region, and we welcome Ms. P. Chan Yong, or PC, as she's known. PC is the president of the Pharmaceutical Society of Singapore He's head of the pharmacy department in Woodlands Health and is an expert on diverse portfolio ranging from hospital management, driving quality care in community setting, logistic and retail pharmacy business setup. PC will be talking to us today about the digital transformation strategy they're applying in Singapore. Thank you, PC.
Thank you, Paul. Thank you, FIP, for this kind invitation as well. Yeah, so as shared, I will be touching on the digital transformation in Singapore and how it does it. But I wanted to share that primarily I will be focusing on the public sector and a little bit on the community pharmacy part. So with these pictures that you see on the slide, I just want to share that in Singapore, actually, we have a strategic health IT master map, which we call heat map. It's actually derived to guide the public sectors in the development of information and communication technology to advance the 3 paradigm shift that MOH has actually asked us to achieve, which is, as you show here, beyond hospital to community, beyond quality to value, beyond to healthcare to health. So embedded in this heat map also included the digital transformation program that the pharmacists desire to embark on improving our pharmaceutical service in Singapore. So essentially, what are they? First is that we have desire to build a single source of truth or medication for our patient, caregiver, and our healthcare professionals. We hope to use the technology to empower the patients to allow them to take care of their health. And third, to increase the accessibility of care by the pharmacists, also to their medication needs. And last but not least, to actually improve our efficiency to provide a better and faster, safer care. So in next few slides, I will share a little bit more on that. Thank you. So with the advent of with the adoption of the IT systems, such as our EMR system, prescribing and pharmacy system, we are able to digitalize our medication records and then share this across to other healthcare professionals or provider through our National Electronic Health Record, which we, in short, we call it NEHR. This then enable the pharmacists actually to perform a very critical role, which is med reconciliation, to derive an accurate patient medication list. And this patient medication list is important tool to communicate to the next healthcare providers, the caregivers, on what the patient is taking at any particular of time. However, if you want to do so, it's important that you do have a very strong in terms of data standards and terminology that to allow the interoperability between the system to ensure safe and unambiguous exchange of information. So for Singapore, actually our pharmacy fraternity, we came together with Ministry of Health as well as our IT office, IHIS, to develop a standardized drug code and terminology, which we call Singapore Drug Dictionary. So all MOH funded IT system now adopt this SDD, and it's actually including not just the pharmacy system, but our GP system, our nursing home system, as well as our hospital EMR system. In addition, I also want to share, I'm actually a pharmacy manager for a new hospital. So I will be one of them to actually benefit of it, is that we will be actually building a new national pharmacy system to replace a legacy system, which is already 10 to 15 years old. So what we hope to achieve is that by harmonize all the national pharmacy system, we are able to standardize our workflow, and we are able to actually support future transformation projects such as Centrifuge, which I will share a bit more, as well as connecting the application, the apps, which is the consumer platform, to our pharmacy system for ease of processing the prescriptions that the patient has requested through their phone app. It also allows us to confer convenience for the patients to collect their medication at any pharmacy, because the patient medication history, their medication balance, as well as their drug subsidy status is shared. Currently, to do so is actually very tedious and laborious for us. Next slide, please. Yeah. So just now what I'm sharing with you is the institution digital transformations. We also have a consumer platform that we tap on. So this is Health Hub. It's actually a consumer platform where your patients can actually not just view the patient medication list. They can also book appointment, check their laboratory, vaccination records. In fact, we actually use this to show our COVID vaccination status as well as our PCR results. So what does the pharmacy do is that we find that this is also a very advantage platform for us to actually to push for our pharmacy patients education strategy. That is to increase the patient and consumer access to the trusted and contextualized health information so that they can then proactively manage their care. As I mentioned, take charge on your own health. So in 2019, all the public sector in pharmacy, together with PSS, which is my society, National Medication Information Work Group, we actually harmonize all the medication information leaflet that coming from all the institutions, and we publish this into this health hub platform. To date, we have already published 300 harmonized MIL in the health hub, and garnering actually more than 500,000 page view from January to August 2021. Next slide, please. This is just a quick sharing that aside from the national digital app platform, institution-wise from the hospital and polyclinics, we also have our institution apps, which we can then actually connect to the patients for the institution-centric services. Next slide. Yeah. So during the pandemics, I'm sure everybody also suffer from the situations that we have to actually conserve our resources. So therefore, outpatient elective appointments was actually cut back. And in addition, we also want to prevent or rather discourage the patient to come to the hospital and polyclinics to collect their medication. And in addition, because of ensuring everybody has adequate supply, we actually restrict the dispense amount to not more than a month to individual patient each time they collect. So hence, actually, there is a need for us to actually allow the patient easily access to pharmacy to collect their next top up, or what we call a medication refill, and actually ask for this medication to deliver to their home easily. So to cater for such a high volume of requests, we actually turn to digital tools. So aside from the traditional phone call, we actually leverage on Health Hub, which I mentioned just now, where the patient to build a feature called medication ordering platform, where the patient can place their order from there, and then we can pick it up from there and then process and send over to the patient address. For those who actually are not so technology savvy, do not know how to use app, we also can send them a form, which is under the Form SG. This Form SG is actually a tool that is actually developed by our GovTech. So it's very secure. As you need to be secure is because you will be indicating your name, your IC, your medication info, which we treat this as a confidential info. So having Health Hub as well as Form SG help us to solve this high volume in terms of medication refill. So aside from actually delivered directly to home, we also look at in terms of leveraging lockers. It may look simplified that actually just drop in the lockers. There's a lot of interfacing looking at control or temperature as well. Yeah, so I won't elaborate here, but just to say that basically our aim in mind is to deliver to the patients at their convenient location and the timing they need. But however, we also recognize in the future, or rather a long-term plan, this is not sustainable for individual hospital or pharmacy to actually do our own medication review. So therefore, you see in the picture there's a strategic trust. Actually, we have an aim to deliver the medication to where and when and how the patients needs it under what we call a National Centrifugal Pharmacy Project. And this actually require, again, a consolidation of our IT system, such as our dispensing system, our billing system, and our patient management system, as well as clinical governance, aside from leveraging on automations to actually improve our throughput in delivering the medication or packing the medication. Yeah, but nonetheless, this is what we aim for, is because it will allow the public sector's pharmacists to focus really on the direct care rather than being brought down by the medication refill. Next, please. So as the medication delivery was actually picked up during the pandemics, we also see the telemedicine services is actually increased in correlations. So in the hospitals, aside from the medication counseling, which we do in terms of teleconsult way, we also have since changed a lot of our ambulatory clinic pharmacists services such as our ACC, anticoagulants clinic, our collaborative prescribing clinics, all into the virtual format so that we can reach the patients who is frail, complex, and even COVID positive patients who cannot actually leave home. And on the other side, in our retail pharmacy colleagues or community pharmacy colleagues, they also expanded their digital technology advancement by offering apps as well as telepharmacy services, whereby the patients can reach them for any inquiry. And it has been very useful because like most of the country, pharmacy was actually allowed to open during our circuit breakers. Yeah, next slides, please. So just a quick one, just to share with you, actually, in most of the public sector hospital or polyclinics, we have already increasingly adopt automation and technology. So for example, in inpatients, we actually have all the iPaaS, what we call inpatient automation system, to help us to harness the closed loop medication management process. At outpatients, we actually use it to reduce the Monday pick and pack and also provide service differentiations through our prioritization engine, such as to prioritize the wheelchair patient first, the elderly patient first, as well as to produce the right language labels for the patients to aid our counseling. Next, please. Finally, I just want to emphasize that all the digital tools are very useful and able to let us do our work better and faster. However, it should not be actually implemented without clear governance and guidance to ensure safety and quality care. So through our journey in Singapore, aside from the Ministry of Health and our Health Science Authority legal and security framework, we actually also went through our digital transformation to actually develop a lot of industrial-led guidelines, which I show in this slide here, to ensure safe practice and use of this enabler. Next. Yeah, this is just my final slides. I thought thank you for your attention. I thought I'll also take this opportunity to thank the people who listed in this slide who actually contribute generously on the material today to share with you. Thank you.
Thank you very much, PC. And clearly, digital enablement and you're embracing digital technology in a very, very sophisticated way. And interesting to see that it's all being driven towards patient education and how that can empower the patient. So thank you, PC. And I won't, at this point, if you don't mind, to the attendees, progress the Q&A because we have a couple of very important sections still to come. We are extending the session for an extra 15 minutes. And any questions that are in the Q&A, if they're not answered directly in this session, we'll take a copy and we will come back to you out of session with an answer for those questions. So it's now my pleasure to introduce two of our FIP staff and very capable and talented FIP staff members. Ms. Nilhan Usman, who is a pharmacist and FIP lead for education policy and implementation, and Nisa Masaita, who is a volunteer FIP volunteer from Switzerland. She's a pharmacist from Indonesia, currently doing her master's degree at the Graduate Institute of International and Development Studies in Geneva, Switzerland. Nilhan, thank you.
Thank you, Paul. I'll be very brief, so we'll continue with our program. Next slide, please. So today, colleagues, we are launching a dedicated FIP website on primary healthcare, where we brought all the information that you may need about primary healthcare, our program areas, and a few more other points that we would like to share with you. In a while, I'll be sharing this link with you, and you may explore this website, and of course, let us know your feedback about our website. So in the next slide, we have listed our program areas from FIP, connecting and aligning our work with WHO, with FIP development goals on strengthening primary healthcare. Our colleague, Dr. Shannon Barkley, will explain WHO's operational framework on primary healthcare and the primary healthcare program in a while. We built our program on the WHO's program, and then we explained how this can be supported by pharmacists in the program areas page. In the next slide, we will be also launching FIP's global commitment section on primary healthcare, listing our commitments in order to achieve Astana Declaration collectively as pharmacists and pharmaceutical scientists. So you will also be able to explore our commitment to action, and this is going to be launched in a while by our CEO, Dr. Catherine Duggan. In the next slide, we also listed our the partnerships we have been having. Firstly, of course, with the WHO and other key partners, that is collaborating with FIP in order to strengthen primary healthcare. So we invite you to explore our site on primary healthcare. And I'll be handing over to my colleague, Nisa Masita, who has tremendously lead this microsite project with me. So I'll hand over to her to present the primary healthcare digital toolkit for you.
Thank you so much, Nilhan. So next up, we have the FIP Primary Healthcare Digital Toolkit, and it is built on the principles of the Declaration of Astana, the WHO UNICEF Operational Framework for Primary Healthcare, and the FIP Development Goals. So in this digital toolkit, for each of the levers of this operational framework, you will be able to explore FIP's publications, digital events, and other FIP programs areas that have been developed following the Declaration of Astana in 2018. So if you look at this, if you look at your screen, under the tab FIP Primary Healthcare Toolkit, you can simply click on one of the 14 levers. So for example, if you click Models of Care, it will take you to all relevant resources. You will see a list of publications, and if you scroll down, you will see a list of digital events and program areas related to models of care. And each of the levers offer you access to numerous resources that are useful to demonstrate the pharmacist's contribution to primary healthcare and the variety of roles and services they deliver. So be sure to check on each of the levers. Yep, thank you, and I'll hand it over to Nilhan.
Thank you, Nisa, for the presentation. And again, we are celebrating the microsite and digital toolkit launch day with you. I'll just share the link with you from the chat box. You may also scan the QR code that you see on the screen. And if you have any feedback, anything you would like to share with us, please connect with us from FIP@fip.org. And we look forward to your feedback and to explore the microsite. Thank you very much. And now I'm handing back to Paul.
Thank you very much, Nisa and Nilhan. That's great work. And that'll be a great resource for, and a very valuable resource for member organisations and pharmacists. I'll now hand over to our FIP President, Mr. Dominic Jourdan, who will moderate the second part of today's webinar. Dominic, thank you.
Thank you very much, Paul. Good morning, afternoon, evening. Dear colleagues, I hope you enjoyed the first part of this webinar. Because we are quite late in time, let me introduce directly our WHO speaker. It's my great pleasure to introduce Dr. Shannon Buckley. Shannon is the Technical Officer for Primary Healthcare in the World Health Organization Special Program on Primary Healthcare, where she leads the work on evidence and innovation. She completed her master's degree at the University of Pennsylvania School of Medicine and an MPH with an emphasis in international health at Johns Hopkins Bloomberg School of Public Health, followed by specialization in family medicine and additional specialization in advanced hospital medicine. Her current work supports implementation of operational framework for primary health care. Throughout her career, she has been involved with the development of effective primary health care among underserved communities globally through direct service provision, health workforce education, health system strengthening, and health policy and monitoring and evaluation. Thank you very much to be with us. Shannon, you have the floor.
Thank you very much, Dominique. It's a pleasure to be here with all of you, and thank you so much for the invitation to participate in this event on this important anniversary of the Declaration of Astana. We also very much welcome at WHO the collaboration of FIP and want to specifically acknowledge their role as a non-state actor in official relations and also the recent memorandum of understanding that has been signed. I think in the activities that we have heard about described by Catherine and just mentioned by Dominique, it's clear that there has been systematic inclusion of primary healthcare and a clear intention by FIP to contribute extensively to the international efforts to carry this agenda forward. I also just want to take a moment to acknowledge the contribution of pharmacists and pharmacist associations to the realization of the vision of the Declaration of Astana, and also their additional efforts during the COVID-19 pandemic. I want to leave time for our discussion, but I just wanted to take a moment to introduce a little bit about WHO's special program on primary healthcare, as it can give you a clear sense of the ways that at WHO we are thinking about our roles and responsibilities in supporting our member states in achieving the implementation of primary healthcare as they have requested us to do. So WHO's special program on primary healthcare was launched in 2020, aligned to the approval of the operational framework. And it was launched with three aims. The first is really to ensure that WHO's work across our 3 billion priorities, and that includes our priority on healthier populations, our priority on universal health coverage, and our priority on protecting people from health emergencies, are connected and synergistically aligned by approaching health systems through the PHC lens. And that looks like using our decentralized network. I think often people connect WHO in their minds to the normative work that WHO does in terms of policies and guidelines, but less often are we visible in our decentralized role, where we have country offices working hand in hand with ministries of health to provide them technical support and strategic support. And so this first pillar is really about connecting the triple billion goals at country level and driving country impact, and enabling the organization to work effectively across those three levels to really deliver for Ministry of Health on technical assistance and strategic support around primary healthcare. All of that is, of course, guided by our country offices. And so something I also like to remind, particularly organizations like FIP and their member organizations nationally, that you can always reach out to your WHO country office. Their addresses are available online through a simple Google search. You can reach out to them and indicate that you would like to be able to support the primary healthcare agenda locally and ask them for opportunities to collaborate. The second pillar is on evidence and innovation, and this aligns to that normative function that I was discussing earlier. We certainly welcome inputs from FIP and our other non-state actors in official relations, our collaborating centers, and our other partners globally in developing each of these technical products, which emphasize people who are often left behind. That includes the operational framework, which we've discussed extensively. This year, we'll also be launching the measurement and monitoring guidance for primary healthcare to help countries track their progress on primary healthcare and identify bottlenecks. Eventually, that will lead to the issuance of a global report on primary healthcare, which has been requested by our member states. In addition, to match that quantitative data, we're preparing a country case study compendium to bring together the work of WHO and other organizations to demonstrate how countries have actually made progress so that to enable cross-country learning around these areas. We're preparing a course on primary healthcare within the WHO Academy, a series of policy briefs aligned to the levers of the operational framework. We'll be identifying best practice country examples in our implementation solutions, which look at not only the technical solutions, but also how countries have really been able to lead and manage change around this health system transformation agenda. And lastly, we're working with our colleagues in innovation and also an International Development Innovation Association to scale innovations that have been shown to be promising in one context with support from our country offices. Lastly, and certainly not least, is policy and partnership. We see our partners as key to delivering on the agenda of primary healthcare. The Declaration of Astana explicitly mentions the role of all stakeholders in driving this agenda, and so we have an entire pillar dedicated to policy and partnership. And this is to enable us to continue the renewal of PHC, to not lose momentum, and to ensure that PHC is really positioned as part of the agenda to build back better, enabling leapfrogging and incorporation of some of the new innovations that we've seen during the COVID-19 pandemic. And with that, I will pause and hand back to Dominique to start the more interactive portion of the session.
Thank you very much. Maybe we can begin with a few questions. I have a question and the following one. What is the perspective at WHO regarding the current status of primary healthcare around the world, or what's on WHO's to-do list for the 2030 agenda?
Thanks very much for that question. As I mentioned, we are in the process of developing the primary healthcare monitoring and evaluation guidance. And part of the reason for doing that is that in reality, a lot of the real state of primary healthcare globally is at least not visible on the global stage or the regional stage. Countries often know where they stand, but it's more difficult to dig through the various information sources that are out there to understand how primary healthcare has or has not progressed. That being said, we do know that there are some countries who've been able to implement this agenda more fully, and others that have done so to a lesser degree. And as a result, we see a huge variation globally in the degree in which, first, that people in communities have the information and opportunities they need to contribute to their own health, to the management of health services, to the passage of policies that promote and protect their health. Secondly, we see a huge variation in the degree to which evidence-based multi-sectoral policies and actions have been implemented by governments around the world. And thirdly, we see a huge variation in the performance of health services, the degree to which they're integrated, and the degree to which primary care or first level care is enabled to be a real hub for the integration of health services. I think we have seen probably the best tracer that we have to date is the UHC coverage index globally. And though we've seen progress on that index over the last few decades, we know that we are still off track to meet our objectives by 2030 in terms of ensuring that everyone has access to the health services they need when they need them of sufficient quality to be able to address their health concern. Right now, we know that the current service coverage index, and there will be an updated report on universal health coverage this year, is above 60. But that is far off where we would like to see it, and it's quite variable from country to country. I think in addition, we know that COVID unfortunately has set us off track even further with regard to service coverage. We know that even a year into the pandemic, as our latest data shows us, over 40% of countries were still experiencing major disruptions across all service areas that are measured in the service coverage index, and that the greatest proportion of those disruptions were in primary care. And so we have a long way to go, but we don't give up hope. I think those bright spots, those countries that have been successful over the years, those countries that were successful before the pandemic and have been able to use their strong primary healthcare orientation as an asset for responding to COVID, enabling them to be more flexible and more community oriented, show us that it's possible. And so we as WHO, along with our partners, are really looking forward to digging into this agenda out to 2030 and beyond to ensure that everyone has access to the help they need and deserve.
Yes, you said we have a long way to go, and pharmacists are willing to help WHO and to help also the universal health coverage to meet the goals. Prevention, patient safety, and management of long-term conditions. These three areas are where pharmacists add significant value, also considering their proximity to the communities that they are serving. We can rightly say pharmacists' role in primary healthcare is more fundamental than ever. And while multiple levers of the operational frameworks, including medicines and other health products, health workforce lever, and models of care have been linked directly with pharmacists and or pharmacies, we believe and have shown that Pharmacist enables all of the levers in the framework. How does the WHO plans collaborate on each lever, and how we Pharmacists can support WHO with delivering the operational framework for a stronger primary healthcare?
Thanks for another great question, Dominique. And they're so easy to respond to also. No, I think in looking at the levers of the operational framework, it's clear that, you know, at a normative level, there's specific guidance needed around each of them. And so we're working very closely with our headquarters and regional colleagues to ensure that the specific, deep technical knowledge that is out there in the world about how to do this successfully is given visibility, that countries are giving clear guidance about how to drive this agenda together. But at country level, these things are really more fully integrated. And really, it's, you know, our health systems teams in country offices led by the WHO representative who lead that agenda on behalf of WHO. And so in reflecting on how pharmacists can contribute, I think there are sort of three key ways that this generally is enacted by almost all health professions. I think the first is by individual pharmacists and working alongside their colleagues, playing their role, their really critical role in multidisciplinary care teams so that people have access to the services they need, to the medicines they need, and are able to improve their lives. And I think the presentations that we saw earlier today went into much greater detail than I will be able to do in this brief conversation that we're having about the ways that individual pharmacists and pharmacy teams contribute in those ways. I think the second is as educators. And I think really looking at the ways that we educate future health professions. I think we already saw in the discussions around Astana with the young professionals from each of these professional societies that the way that we're doing education in a more multidisciplinary, interdisciplinary way is really leading and giving us huge dividends in terms of willingness of different professions to work together to achieve shared ends, and that we're no longer in a situation where people see, you know, in our future generations, we're no longer in a situation where people see a gain by one profession as a loss by another, and a greater ability to see mutual wins and ultimately mutual wins for the people that we serve. And I think contributing as as pharmacist educators to that agenda is really critical. And then lastly, and I think perhaps the way that we interface most clearly as WHO is in the advocacy role of individual national member associations, or even as FIP on the global stage, or regional associations, ensuring that we are driving together, advocating together for these types of transformations that need to happen at national level. And I think some of that happens at global level with contributions from FIP and other member associations, professional associations, to our normative guidance, and ensuring that we're issuing the kinds of guidance that we need in order to make a difference for people on the ground, but also ensuring that at country level, the interface between WHO, between ministries of health, between professional associations is strong, and that we're providing unified guidance for the way that these transformations can be driven forward.
Thank you very much. And we have seen the part one that pharmacists from the United States of America, Jordan, Singapore, the Netherlands, Indonesia, and Kenya showcased how pharmacists can utilize and contribute to the WHO operational framework. Could you give some recommendation or specific pharmacy recommendations how we could be more efficient in collaborating with WHO?
Yeah, with pleasure. I think, you know, it's interesting. The operational framework is sort of divided into these two levels, the strategic levers and the operational levers. And as you mentioned, we heard from our presenters just now, really great detailed examples of how the operational levers and their interrelated actions can be used and supported by pharmacists in national contexts. I think we also have the list of strategic levers, which tend to be things that are perhaps more difficult to invest in directly, but link directly to that advocacy role that I was discussing earlier. The strategic levers are political commitment and leadership, which I think it's been shown quite extensively that that's one of the most critical elements for a country to actually make progress on this PHC agenda. And that can often be a challenge because political appointees in the Ministry of Health change over rapidly. And so what it requires is a really strong technocratic and bureaucratic element that is committed to this agenda moving forward and that enables it to be politically viable for ministers of health as they assume this role and try to carry forward a really important vision. I think on governance and policy frameworks, the contribution of everyone to a unified national health sector policy and strategy and plan with the detailed elements that are required for subsectoral strategies is one of the only ways that we can do this in a coordinated way. And I think our colleagues gave great examples of the way in which even those operational levers communicate back to the policy environment, and that it really requires everyone working together to ensure that the policy environment enables and allows for the types of transformation downstream that we're driving toward. Funding and allocation of resources, I think, is another key area. We talked a little bit, several presenters talked a little bit about benefit packages or reimbursement models for pharmacists themselves, and how critical it is that we get those upstream elements, the benefit package and its linkage to an essential medicines list. The actual payment mechanisms that are employed to pay pharmacists and also the broader primary care team, and ensure that we're incentivizing the types of service delivery and the types of models of care that are best fit to each country context to enable this transformation. And then lastly, on the engagement of communities and other stakeholders, I think that speaks to the role that each of these associations play in national dialogues around the national health sector plans, strategies, and policies. It also speaks to the roles that pharmacists have at subnational level in their communities. We heard about the close proximity that pharmacists have as a trusted provider in the community, and being able to give people the information that they need to be able to manage their health well, but also the information that they need to navigate the health system, which can sometimes, particularly for people with chronic conditions, be very complex. So I think on each of those strategic levers, there are actions that can be a contribution of the pharmaceutical associations themselves, but also of individual pharmacists in their subnational locales.
Thank you very much. Nilhan, do we have some questions from the attendees?
Sorry, I was on mute. I was speaking. Sorry. The questions that came from for WHO have been answered in the panel. So we already discussed this. And also we skipped the other Q&A parts in the first part, and our speakers are answering the questions already. So we may
I have a last question, because this is also an important one. What does the success look like for a strong primary healthcare system for WHO?
It's difficult to say it more effectively, I think, than it was said in the Declaration of Astana, and I feel, really proud is the wrong word, but really inspired, I think, by the words that our member states pulled together. And it's not often that a declaration like this begins with a vision. And I think the fact that it did speaks to the idea that, the world has come together and really has a shared vision of what we're driving toward. And what that means is that governments and societies are prioritizing, promoting, and protecting people's health and well-being at population and individual levels. That primary healthcare and health services are high quality, safe, integrated, accessible, available, and affordable for everyone, everywhere. And that enabling and health conducive environments where people are empowered and engaged in maintaining and enhancing their health are available. And lastly, it's certainly not least in this context, that partners and stakeholders are aligned in providing effective support to national policy strategies and plans. And for me, it's difficult to say much better than that.
And that nobody will be left behind. This is quite an important one.
Everyone, everywhere.
Yeah.
No one's left behind.
Thank you very much, Nilhan. I think we are finished because of the time.
We have few points to wrap up today. If Aysu can share her screen. We will wrap up today with the launch of the commitment to action, Dominic.
I just want to thank Shannon for this discussion and being with us today. It was my pleasure to chat a little bit with you, Shannon, about your goals and the goals of FIP, and you could see a little bit what the pharmacists are able to do when they are committed to actions. And this is quite impressive what my colleagues are able to do in the regions. And I'm happy that you could be part of this webinar today. Thank you very much. And I hope we will have more collaboration in the future.
Impressive indeed. I look forward to it. Thank you again.
Thanks. Nilhan, back to you.
Thank you, Dominic. So colleagues, our CEO, Catherine Duggan, would be normally presenting FIP's global commitment to action on primary healthcare to you right now. It's a pleasure for us to launch this commitment today after all these exciting presentations and the panel with the WHO. I'm handovering her presentation because she has to leave for the World Health Summit, which she is going to represent pharmacists there at a summit with other healthcare professionals. So she sends her apologies. And it's a pleasure for us to launch the FIP Global Commitment to Action on Primary Healthcare. This is going to be on our website, which I'm also going to share the link in a while for you to explore. This is basically going to be our to-do list as pharmaceutical scientists. In order to strengthen primary healthcare, we'll address each item with your support with our countries and members. This declaration is simply building on the principles of Astana Declaration, FIP Development Goals, and WHO UNICEF's operational framework for primary healthcare. So this is basically translating all these principles into a to-do list for pharmacists. We invite you to explore this commitment to action, and we'll be working with you towards 2030. We explained you our journey, and we aim to achieve all of these 15 commitments to action, and we believe together we can, and we will achieve universal health coverage, good health and well-being for all by leaving no one behind. This global commitment to action is also provided to you by our FIP Bureau colleagues who are the leaders of FIP. And in the next slide, it's my pleasure to also provide you the commonly mentioned words in the commitment to action. Normally, Catherine would be presenting this much more better than me, but we just wanted to show you is we mapped the words in the commitment to action, and of course, primary healthcare, but prevention, safety, non-communicable disease, public health, pharmaceutical care. These are the most commonly mentioned. So also based on the discussion with our WHO colleague, Dr. Barkley, these will be the key areas where pharmacists and pharmaceutical scientists will add value to the primary healthcare. And in the next slide, you may also see our next steps, but I'll hand over that part for our President, Dominic Jordan, our journey towards the Health Minister Summit for his wrap-up points. And I just shared the link to the commitment to action from our chat box for today. Also, you may access to this from our microsite as well. Next slide, please. That's all from my side. And we will skipping the questions and answers. And in the next slide, I'll hand over to our President, Dominic Jordan, for his closing remarks. And sincerely thank to everybody for staying extra almost half an hour, and to our chairs, Dominic, Paul, and our wonderful speakers. It was a pleasure. Thank you very much. Over to you, Dominic.
Thank you, Nilham. I will be brief. I just want to thank first the chair of the BBP, Paul, to have co-moderate this session with me, and also all the panelists for sharing their impressive work that they have done in the regions. And these are concrete projects, and the outcomes are very are great because they are focused on the benefit of the population, especially to Roy and to Zaid, because we signed commitment with them with Indonesia for workforce development and a commitment in Jordan for primary healthcare. And as you can see, it was not only a paper with signature, but they have delivered outcomes for the benefit of the population. And this is what in my slogan is written in: trust, solidarity, and actions. Actions for the benefit of the population. And this is the way that we will work until at the end of my presidency. In 2023, you know that we will have Health Minister Summit, and I want to have facts on the table to prove to them that when pharmacists are involved in projects, the outcomes for the population is very good. At the end, I just want to thank also all the people involved in the headquarters for organizing this webinar, and also a big thank you to all of you from all over the world for attending this webinar. I hope you enjoyed it. I hope you could learn some, or you can learn a lot and take home some messages, also some project that you can try to implement in your region. If you have some question, do not hesitate to contact the headquarters and we will try to give you the adequate answer. Thank you very much again, and have a nice night or day, depending from where you are, and see you soon. Bye-bye.
Thank you, colleagues.
Thank you to all.
Thanks, Dominic.
You're
Thank you,
welcome.
colleagues.